Okay, good morning, everyone, and thank you so much for joining us today on this webinar on sleep and fatigue with Dr. Baumgartner, who's here with us today. My name is Elena Kussler, and I am the Program Director for the Parkinson Association of the Rockies, and I'll be helping to facilitate today's webinar. So a couple of things before we get started in terms of housekeeping and process. We will be hosting a Q&A session at the end of the presentation. So hold your questions until then, or write down your questions so that way you can ask them at the very end of the presentation. There are a couple of different ways that you can ask your question. The first, if you navigate to your control panel for the GoToWebinar, there should be a little questions tab. Go ahead and click on that, type your question in there. That question will come to me and I'll pop on the very end and ask that question to Dr. Baumgartner. The second way that you can ask questions, if you would like to ask them directly, you can use the raise your hand function on the control panel and we can unmute you, and you'll have to unmute yourself as well, and you can ask your question directly that way. A note, this presentation will be recorded and available to you in a follow-up email that will be sent around this time tomorrow, or it will be available on our YouTube channel, hopefully by the end of today. So keep an eye out for that. Feel free to share it if you'd like, or watch it back when you would like. We don't have any handouts actually for this presentation, so you can disregard that note. But there may be some in the follow-up email, so keep an eye or go ahead and click on there tomorrow if you'd like to check those out. And last but not least, there is a survey at the end of the presentation for you to fill out. That just helps us get some information and improve our programming overall. So please take a minute, no more than 2, to fill that out and submit those. We have quite a few webinars coming up over the next month or so. All of these are webinars that are available to you for free and can all be found in the registration links at parkinsonrockies.org/educational seminars. In addition to those, we also have a series called Parkinson's 101 that we developed in 2019, and it's a 3-part series, and each session is held about a month apart. The first session is all about Parkinson's basics, what it is, what the symptoms are, even possibly where it comes from. The second is all about medications and how those are interacting in your body. And the third, we have kind of revamped that, and it is now about exercise and talks about how much, how intense, all of that, and it gives you some great numbers to reach for. All of those sessions can be registered for at parkinsonrockies.org/PD101. So be sure to check those out. And the last one, I promise, is our Colorado Community Conference is coming up on Saturday, April 24th. This conference is all about research. We're talking about things like sleep in Parkinson's, the gut in Parkinson's. So a fuller list of our sessions is available on the website, and you can also register there as well. And of course, if you have any questions, feel free to email me. So with that, I'll go ahead and transfer over power to Dr. Baumgartner.
All right, can we see my screen?
Sure can.
Excellent. All right, thanks so much, Elena, for hosting and facilitating. And thank you to all of you for tuning in today. My name is Alex Baumgartner. I'm one of the fellows in movement disorders at the University of Colorado, and I think I've met some of you in the clinic in person, and also probably have met some of you or was introduced to you when I spoke about alternative therapies in Parkinson's a couple weeks ago. But it's my pleasure to be talking to you today about sleep and fatigue in Parkinson's disease, one of the most common issues that we deal with in nearly every patient with Parkinson's. So just a couple words of disclosure. I have no significant financial obligations or relationships to disclose to you. As I said before, every person with Parkinson's is unique, as are their responses, their different symptoms, and how things might progress over time for them. So just keep that in mind as we talk about different symptoms and managements, that what works for one person or what one person experiences may be very different from what other people's experience. So just by way of an overview, we'll talk a little bit about the difference between when we say fatigue and sleepiness. We'll dive into those individually, just a few words on fatigue, potential causes, and what we think about for treatment options. And then the bulk of the time we'll spend on sleep and sleep disorders, how important sleep is for everyone out there, especially people with Parkinson's, some of the most common sleep disorders that we see both in the general population, but especially in people with Parkinson's, and then some treatment options for each of them. And then we'll have some time for wrap up and questions at the end. So is it fatigue or is it sleepiness? It's one, I think it's first important to know that it's very difficult to sometimes recognize the difference and to parse out the two. And in a lot of people, both in the normal population and in people with Parkinson's, it's very common to have issues with both. But when we try and separate out the two, we usually make this distinction that sleepiness is the tendency or ability to fall asleep. And that is obviously in part a normal process that as the day winds down, we feel this increasing desire and tendency to want to be asleep. But I think that may creep in during the day and at other times when it's inappropriate as well, which can range from very mild, tending to fall asleep if you're sitting on a comfortable couch at the right temperature and there's nothing distracting you and no blaring TV or music, to very extreme and very inappropriate times when you might have a tendency to fall asleep at the dinner table, or God forbid, when driving a car or operating a vehicle. So that's the distinction we're trying to make there. When we say fatigue, that's a little bit more difficult to define, and there's really no universal definition that's specific to people with Parkinson's or to the general population. But this is a kind of a more broad sense of tiredness, feeling very exerted, feeling a lack of energy. And so people will use a whole lot of different words for this. They're exhausted, they're drained, they have no energy, they're wiped, pooped, you name it. But this is a little bit broader than specifically that tendency or ability to fall asleep very easily. So let's talk a little bit about fatigue. When we as neurologists talk about fatigue, we often think of two different types. And making this distinction can be helpful, but is not always necessary. A peripheral fatigue usually refers to a muscle problem where the strength, coordination, and dexterity of movements tend to decrease as you repeat the movements. And then we also talk about central fatigue, which is kind of that more exhausted, wiped, drained, lack of energy type feeling. And that can have both kind of mental and physical manifestations. And it's important to know that people with Parkinson's have both of these problems, both a peripheral problem with fatigue, where the more you do things, including writing, some of the things your doctor may do with you in the clinic, like tapping your fingers or tapping your toes, all of those things tend to get a bit smaller, slower, and less coordinated the more you do them. And people also have this central, wiped out, exhausted feeling, more common in Parkinson's than in the general population. And pretty much all of us in the past year have had this new phenomenon called Zoom fatigue syndrome, where we're spending all our days in meetings and webinars, that sort of thing. And so I hope I'm not contributing to that too much, and hopefully that you'll get something out of this as well. So what are the causes of fatigue? Well, there are a whole lot. And like we said, one of them is just being a person with Parkinson's itself. We know that those people are more likely to experience fatigue than the general population. But in terms of other medical or mental health or neurologic issues, you name it, and they can really cause fatigue. So those would include depression, side effects of medications that can be sedating and cause fatigue. Poor sleep can cause fatigue as well, in addition to just sleepiness. And so that's why it's often difficult to parse out that difference between fatigue and sleepiness, because one can cause the other. And there's certainly a reciprocal effect with both of those. But issues with sleep, including insomnia, having to go to the bathroom frequently overnight, sleep apnea or other problems with breathing, and other sleep disorders, which we'll talk about in the next part of this talk, certainly can cause fatigue. People with dementia, or what we call mild cognitive impairment, meaning more subtle problems with thinking and memory, are also more likely to have fatigue. And then medical issues as well that you might talk with your primary care doctor about, like anemia or low blood counts, orthostatic hypotension, a problem where the blood pressure drops drastically when you go from sitting or lying to standing up, will also lead to fatigue. Thyroid disorders, especially hypothyroidism, can particularly cause a lot of fatigue. And then, like I mentioned, the progression and the fact that you have Parkinson's itself. So when we think fatigue is the main issue, what do we do in terms of treatments? Well, first, we focus on managing the times that are good during the day, and that's what I mean here by energy management. If you know that a certain part of the morning or afternoon is the time when your energy is at the highest, make plans to make use of that time. Get your exercise in during that time. If you need to run errands, do it during that time when you know energy will be at its maximum. Try and budget your energy over the day, meaning don't try and get everything done in an hour, but know that you may need to take breaks, slow down during a part of the day when the energy is lower. And for some people, power naps, meaning naps that are about 20 to 30 minutes in duration, can be very helpful in just providing a little boost of energy that can help you get through the rest of the day. We also know that exercise is critical for both preventing and then treating fatigue, and people who exercise regularly are much less likely to be bothered by fatigue. And that's due to a whole host of reasons, but not only the cardiovascular benefits, but the neurologic benefits of fatigue, of exercise on fatigue as well. Maintaining a stimulating environment is important, including, having bright and natural light in the home if you're at home, not staying in the same room with the same, background noises, TV, etc. But even doing things like changing rooms, adding some lights. Some people in particular find bright light therapy useful, and I mentioned that during the last talk I gave. Those wide UV spectrum lights that can kind of simulate a natural sunlight type environment. Doing things to keep your brain active, even if it's not exercise, things like crossword puzzles or jigsaw puzzles, you name it, to try and keep the brain active and engaged. Thinking about removing any sedating or fatigue-inducing medications and talking about that with your neurologist and or your primary care doctor would be a good idea. And then the question comes up, should we use stimulants? And these are medications that are often used to treat things like ADHD or help maintain alertness. It's a little bit unclear when the problem is just fatigue in itself. We'll talk about a little bit more of that in the sleep section of the talk as well. So let's move on to sleep disorders. First, why is sleep important? We know that everyone needs to sleep, and we know that everyone needs high quality sleep. And when we talk about sleep, we talk about one, not only the quantity, how many hours are you getting, but what's the quality, and that means how often are you waking up? Are you getting the deep sleep that we know that is important for things like memory consolidation? And is it consistent? Are you getting that same quality and quantity of sleep 7 nights a week? And it's pretty well known that sleep is important for all kinds of issues. I've listed some of them here, but those include memory, thinking, mood and energy level, physical performance, both in people with Parkinson's, but in very young athletes, that sort of thing as well. Alertness. It's very well known that problems with sleep can have deleterious effects on all of these things. But unfortunately, sleep disorders are very common in Parkinson's disease, and we think as many as, or as high as 90% of people with Parkinson's may have some form of sleep disorder. But the silver lining is that most sleep disorders are actually treatable in one form or another, and there are significant improvements in sleep and in quality of life that we can make by addressing these sleep disorders. If that wasn't enough to convince you that sleep is important, here's a slide just demonstrating all the effects that we know that poor sleep can have on mental and physical health. And with mental health, we know that there can be problems with irritability, problems with thinking, memory loss, lapses in judgment, yawning that can become very distressing and embarrassing during the day. We know that for people who have hallucinations, those are likely to get worse if they're not sleeping well. People can have trouble focusing, kind of looking like ADHD. And there are various other general or medical issues that come along with this as well. We know that the immune system doesn't function as well. There's a higher risk of things like diabetes, other heart diseases, heart attacks, high cholesterol, problems with muscle coordination and movement, which are particularly important to people with Parkinson's, decreased accuracy and increased reaction time, which can be really important if you're driving, of course, but in other day-to-day tasks as well. We know that risks of obesity are higher in people who don't sleep well. So really important to think about all of these things when we're thinking about sleep. So let's talk about some common sleep disorders that we see, especially in people with Parkinson's. And far and away, one of the most common is REM sleep behavior disorder. We'll often abbreviate this as RBD. REM sleep deep behavior disorder refers to abnormal movements that occur during REM sleep. REM sleep is the rapid eye movement deep sleep where most of the vivid dreams occur, not necessarily all dreams, but most of the really vivid dreams where it seems like real life are occurring. And in people with REM sleep behavior disorder, the easiest way to think about it is they act out those dreams. Whereas normally the brain works to paralyze all your muscles except for the diaphragm, which allows you to breathe, and except for your muscles that move the eyes during that period of sleep so that you're not acting out those dreams. We know that REM sleep behavior disorder is potentially harmful both to the person who experiences it and to anyone they share the bed with, because things like punching, kicking, and hitting are very common symptoms of REM sleep behavior disorder, and people can end up with injuries from being hit or kicked by their bed partner. People also can even fall out of bed and cause injuries to themselves that way. We know that REM sleep behavior disorder typically occurs about 90 minutes after sleep at least, if not later. And that's because that's when people, as you sleep, enter the REM phase. Things that can look like REM sleep behavior disorder we'll talk about a little bit, but those things usually happen, immediately after falling asleep or as you're lying down in bed. And that gives us a clue that the REM sleep behavior disorder is probably not the issue if that's what you're experiencing, because we know that it takes generally about an hour and a half to enter that first REM phase of sleep during the night. So specifically in people with Parkinson's, we think that somewhere between 25 and 50% of people with Parkinson's have REM sleep behavior disorder. And interestingly, this can actually be one of the first symptoms of Parkinson's that occurs well before anything like tremor, trouble walking, slowness of movement, or stiff muscles. And in some people, even decades, 2 or 3 decades, they can have the REM sleep behavior disorder before they might experience the more typical symptoms of Parkinson's. And we know from looking back that people who have REM sleep behavior disorder are very likely to have Parkinson's or a similar condition down the road, and that number may be as high as 90%. Which I think is a little bit disconcerting in some ways for people that may develop REM sleep behavior disorder, worrying that there's probably a high likelihood that they may develop Parkinson's. But I think it's also very exciting to think about this as a potential marker very early on of the development of Parkinson's disease, and hopefully it won't be too long before we are working on medications to really stop or slow down the development of Parkinson's, which are probably going to be which will be need to develop very early on in the course of the disease before a lot of the degeneration of the brainstem and other parts of the brain has taken place. So I think that this is really exciting to think about this as a marker where we could know that you may be at risk for Parkinson's very early on, and hopefully in the near future be able to do something about it. So what symptoms might you notice if you have REM sleep behavior disorder? Well, that's a bit of a rhetorical question because people themselves don't usually notice the symptoms. You are in a deep REM sleep and are not aware that you are doing and acting out these dreams, but it's typically the person who shares the bed with you that will notice these symptoms first. And a lot of the common dreams that people report are in some way related to them being under duress or under attack. And that's often fighting someone off or having to run or escape from someone. You can see in this illustration here, this gentleman is reenacting or living out a boxing match and is doing just what you might expect for a boxer to do. He's holding his fists up and probably going to make some punches or jabs with his fists, which can obviously be quite dangerous to whoever you're sharing the bed with. But other things that people report are yelling out or talking during sleep, having conversations with your bed partner, movements, like I said, that are often very violent, kind of punching, hitting, kicking. What we typically don't hear is sleepwalking or somnambulism would be the medical term for that. But this is different than people, getting up in the middle of the night. Maybe they feel like they're in a deep sleep, making their way to the fridge and making a snack or having a drink, that sort of thing. Those kind of more complex movements are not typical of REM behavior disorder. It's usually much more simple single movements, hitting, kicking, that sort of thing. So let's talk about some treatments for REM behavior disorder. I'm going to move from the most simplest and non-pharmacologic or non-medication based treatments into the medications and other treatments that we have. So the first is just making sure that the environment is safe for you if you were to do things like hit, kick, punch, or even try and jump out of bed. And that means making sure that your bed is close to the ground so that if you were to fall, it wouldn't be a very far fall. Some people with very severe REM behavior disorder put the mattress on the floor, and so there's really no more than 6 or 8 inches between them and the floor. Some people have either special modified beds with side rails or even have a hospital type bed in the floor. And so putting padding on the side rails can be a good idea so you're not going to hit, kick, or otherwise harm yourself against those. You want to make sure to move away any sharp objects like nightstands or other furniture that could cause cuts or bruises if you were to scrape yourself on it. For some people, they find it's necessary to sleep in separate beds from their partner just to avoid those hits or kicks in the middle of the night. And some people have even told me that they find it useful to sleep in a sleeping bag where they can zip themselves up and be kind of constrained in the sleeping bag so that they won't be jabbing, hitting, kicking during the middle of the night. If those things are not effective, or even at the same time, we might think about adding a medication as well. And the first one we'll typically recommend is melatonin. Melatonin is a natural sleep-promoting hormone, that's made in the brain and helps promote both falling asleep and then also that deep REM sleep. And this can be quite helpful for people with Parkinson's. You can buy it over the counter, and there are a whole lot of different formulations. In terms of dosing, I'd recommend talking to your neurologist about it, but most people are on a dose of somewhere between 3, 5, 6, maybe 10 or 12 milligrams, although in some cases the dose can go higher. And there are long-acting formulations that are sold at various pharmacies, and I believe that Costco has their own formulation as well of a long-acting version of melatonin that's meant to last for several hours, 6 or 8, basically the whole time you're asleep. If symptoms are still very bothersome despite things like melatonin, we might think about a medication called clonazepam, which was initially developed as an anti-seizure medication, is also used now to treat anxiety. It works by slowing down some of the signaling in the brain, and so that leads to its effect on REM sleep behavior disorder, but that also leads to things like side effects that can include drowsiness, falls, trouble with thinking and memory. And so we're a bit hesitant to use that medication first line, but if symptoms are severe, it can be very helpful in treating the movements of REM sleep behavior disorder. All right, moving on to restless leg syndrome. This is also one common in the general population, but more common even in people with Parkinson's disease. Here are the criteria we think about considering whether or not someone has restless leg syndrome. And officially, you need to meet all these criteria in order to be diagnosed with restless leg syndrome. First, there needs to be an urge to move or an unpleasant sensation, typically in the legs. Some people will call it an itch, ants crawling on my skin, just a sense that you need to move, can't sit still, any of those words. It typically happens during periods of rest or inactivity, so most commonly when you're lying down in bed, but can also occur if you were lying on the couch or sitting in a comfortable chair. And a movie theater can be problematic for people as well. Not that we're going to movies these days anyway. And this sensation or this urge is at least partially or completely relieved by getting up, moving around, stretching for as long as you're doing that activity. And typically these symptoms are worse in the evening or at night. Like I said, typically when you're lying in bed trying to fall asleep, although in some cases they come on earlier and earlier during the day. So specifically in Parkinson's disease, we think that restless leg syndrome occurs in as high as 30% of people, so about 1 in 3. We know that there are other medical conditions that can be associated or can even cause or worsen restless leg syndrome. And in particular, those include low iron, even if you don't have officially anemia. Kidney disease or renal disease, which is very common in things like diabetes, also neuropathy or any sort of nerve damage. Pregnancy is also a very common cause of restless leg syndrome. Typically, the diagnosis is made by just speaking with your physician, and we don't need things like formal sleep studies, although in some cases, if there's uncertainty about what exactly is going on, your doctor may recommend a sleep study, which we'll talk about in a little bit as well. So what can we do to treat restless leg syndrome? We want to make sure that we eliminate anything that may be making it worse. And so that would be one, looking for those other conditions that can make things worse, like kidney disease, diabetes, neuropathy. You should talk with your doctor about checking for all of those things. We know that certain medications often make the symptoms of restless legs worse, and those include antidepressants, like the SSRIs or selective serotonin reuptake inhibitors, Prozac, that sort of thing. Antihistamines that some people use either for allergies, like Claritin, Allegra, or sometimes ones that people use to fall asleep, which would include things like Benadryl or Tylenol PM, Advil PM, that sort of thing, can also make the symptoms of restless legs worse. And so if you're using something like Tylenol PM to help you fall asleep because of your restless legs, probably the best solution is to just cut out the Tylenol PM as the first step. Things like nicotine, caffeine, and alcohol can also make restless legs worse, and so avoiding those in particular close to bed or in the afternoon or evening is critical. But if that doesn't work and restless legs are still severe, it may be necessary to totally cut out caffeine or alcohol. A lot of people find that doing things like exercising, a bit of stretching, getting the legs moving before bed, or putting the legs in a warm water to soak, warm bath to soak, can be very helpful as well. We often recommend that people add iron-rich foods to their diet, and that includes most enriched grains like cereals, breads, etc., but also things like that are good sorts of protein in general often have a lot of iron as well. So beans, tofu, certain seeds, nuts, and then a lot of animal-based protein as well, including chicken and some seafood like mussels, and oysters, beef as well. And then for many people, we often recommend iron therapy, whether that's as a pill or in some cases as an IV dose of iron that you would get. And it's important to recognize that iron levels that are normal according to a lab are normal in reference to, do you have anemia? And that's the iron level necessary to improve the symptoms of restless legs may be a bit higher. So it's not uncommon that people, even though their iron level is normal according to the lab, may benefit from receiving iron, like I said, either as a pill or an IV form to treat their restless legs. If those things aren't cutting it, we'll often think about adding medications as well. Some of the most common are gabapentin or pregabalin, and those come in a couple different forms. I have the brand names listed for each of those there. Some side effects to be aware of are mostly sleepiness and grogginess, and some people leg swelling. And for those reasons, at least the first two, we often have people take this just at night or about the time their restless leg symptoms typically begin. Other medications that we could use include what we call dopamine agonists, medications that affect the signaling of dopamine in the brain. And those are things like pramipexole, ropinirole, or in particular a patch that lasts 24 hours called rotigotine or Nupro. These do have a bit more in terms of side effects, and those can include sleep attacks or falling asleep for no reason when you're not even all that sleepy. Problems with impulse control, meaning gambling, shopping, spending lots of money, or doing things compulsively that you didn't do previously. And this other phenomenon called augmentation, where in particular with medications like the dopamine agonists, the symptoms of restless leg may start earlier in the day or in the afternoon. They may be more severe. They may spread to things like your arms. And where we really get in trouble is if you then start taking more medication to try and treat that, but then that more medication makes this augmentation problem worse, and you get in this kind of vicious cycle where symptoms are much worse and you're taking more medication. And in that case, the answer is probably to get you off or decrease the dose of the medications, in particular these ones, the dopamine agonists. For severe cases, opiate medications can be very beneficial, and those will include things like tramadol or oxycodone. Methadone in particular is a long-acting version of an opiate, so it can be quite useful because you're not having the ups and downs of dosing each of those medications. But of course, those come with a whole host of side effects that we need to be aware of, including things like constipation, trouble thinking, in some cases dependency, especially with medications like oxycodone. A disorder that comes along frequently with restless leg syndrome is periodic limb movements in sleep, and these are jerky, very stereotyped movements, typically of the legs, that happen usually as you're falling asleep, or after you've been asleep for not very long. Typically, it looks like you're bending your hip and knee in a very fast and jerky movement. And they come periodically, meaning there's usually a rhythm to which they come every 15 to 30 seconds. These happen in people both in the general population, occur more frequently as we age, and are also more common in Parkinson's disease and more common in people who have restless leg syndrome. They're also strongly associated with things like heart disease and kidney disease, much in the way restless leg symptoms are as well. And some medications can make them worse as well, including especially those antidepressants. Now, if you have periodic limb movement disorder, that means that you have a certain number of periodic limb movements per hour, and that number, according to official criteria, is 15 or more in an hour. And if it causes you symptoms in the rest of your day-to-day life, that includes, trouble falling asleep or staying asleep, or sleepiness or fatigue during the daytime, then you might get a diagnosis or might talk about what we call periodic limb movement disorder. And for that, treatment is similar to that of restless leg syndrome, but those medications like benzodiazepines, which would be things like clonazepam or lorazepam or Ativan, would be particularly helpful. And then similarly, those dopamine medications like pramipexole or tigatine can be helpful as well, but knowing that they do have those side effects like I mentioned before. Somewhat similar but a bit different are hypnic jerks or sleep starts. These are jerky movements usually that involve the whole body that feel like a shock, or you're falling into the void or falling down a flight of stairs, typically as you're making that transition from being awake to sleep. These also, are present in the normal or general adult population. As many as 70% of us have them. And they are typically made worse by things like fatigue, stress, poor sleep, exercise, especially right before bed, and stimulants like caffeine and nicotine make those worse as well. So if those are bothering you, we often think about, what triggers or exacerbating factors can we eliminate, in particular things like caffeine, nicotine, and how is your stress and energy level in general. Let's move on to sleep apnea. Also, again, very common in the general adult population, but seems to be more common in people with Parkinson's disease. Sleep apnea, especially when we say obstructive sleep apnea or OSA, is a problem where the back of the tongue and palate collapse against the airway as you're asleep, leading to problems with the normal of airflow in and out. And that happens during deeper sleep, which means that your brain naturally wakes you up, whether you go back to fully awake or a very, very light sleep, in order to more volitionally open up that airway. Typically, the awakenings are very short, and you may not even realize that you're waking back up until we get to a formal sleep study, which can monitor things like your level of sleep, oxygen numbers, that sort of thing, and tell us how often you're having these wake-up events. To be diagnosed with sleep apnea, you need to have at least 5 per hour. Although it's certainly not uncommon that we see people with a lot more, sometimes 90 or 100 events per hour, which of course means more than 1 a minute. So if you can imagine, if you're waking up once a minute or several times an hour during the night, you're not going to feel very refreshed in the morning. I think important to keep in mind, although it's so common for people to snore, it's really not a normal part of sleep, and it's probably an indicator of at least some degree of sleep apnea. So we'll hear people say, I snore, but I don't think I have sleep apnea. And we're a little bit skeptical when we hear that, because snoring is probably a pretty good indicator that there's at least some degree of apnea going on. The snoring is produced from specifically the air moving against that closed or partially blocked off airway that's caused by the tongue and palate collapsing against the back of the throat. And it's well known that sleep apnea has a whole host of deleterious effects on both neurologic health and your general health as well. And that includes things like increased risk of high blood pressure, obesity, feeling sleepy, not restored during the day, increased risks of car accidents, other cardiovascular diseases, and things like diabetes. Headaches and strokes are more common, problems with the lungs, and problems with thinking and memory. So you name it, and sleep apnea would probably make it worse, which is why it's so critical to find this and get it treated. So how do we diagnose it? Well, typically with a polysomnogram or a formal sleep study. If you do it in a lab, you'd kind of look like this cyborg-looking person here with a bunch of sensors and electrodes hooked up to them, and sensors and belts that measure the movement of the chest and your effort of breathing. Typically, this can be done in one night, and now it's very common for sleep studies to be done actually at home, where you'd go home with some equipment to wear and then bring back the equipment the next day, so you don't even have to spend the night outside the home. Treatment of sleep apnea, far and away the best thing is positive pressure ventilation, or CPAP, which just uses a little bit of pressure delivered via a mask that either goes over your nose and mouth, or in some people just the nose, to keep those airways open. For people that have a really difficult time wearing the mask, things like just using a little bit of oxygen at night, and some people find devices like a mouth guard essentially that pulls the jaw a bit forward to keep the mouth open better, but those things are nowhere near as good really as CPAP, or in some cases BiPAP, in order that uses the oxygen to keep the airways open. All right, moving on to insomnia. What do we mean when we say insomnia? Well, that can be, again, problems with the quality or quantity of sleep, either the inability to fall asleep within 30 minutes of lying down and lights out, or waking up frequently or multiple times during the night, or waking up too early in the morning. This is, we think, probably the most common sleep disorder in Parkinson's disease. The estimates are widely variable, but probably as high as 70, 80, maybe even 90% of people experience some form of insomnia in Parkinson's. And we think that simply the cause of insomnia is an imbalance between two natural drives in your body, one, the drive to be awake, and two, the drive to be asleep. And there's a natural rhythm to those that goes throughout the day. It's illustrated in this drawing here. For a typical person on a normal sleep-wake schedule, not someone that works night shifts, that sort of thing, cortisol is released around 6 in the morning, which helps promote wakefulness and alertness. We think that the highest period of alertness and attentiveness is right about now, 10 to 11 in the morning. So I'm glad I have you at this time and not, at 4 in the afternoon. We know that there's usually a lull, typically in the afternoon periods, especially after lunch, where things like attentiveness are a little bit lower. And then as the evening draws on, we know that melatonin secretion begins, 9, 10 in the evening, typically for most people, which promotes sleep, cools down body temperature, and helps promote that natural sleep cycle. And when this gets dysregulated for a whole bunch of reasons, people have insomnia. So what are the causes? Well, there are a whole lot of them. Some of the most common ones we see are dysregulated sleep cycles, going to bed too early or really too late, I would say. And for that reason, we often recommend people take or keep a very consistent sleep schedule, where they're going to bed at the same time every night, waking up at the same time every morning, regardless of whether it's a weekday, weekend, that sort of thing. Napping for too long during the day can really throw off that sleep cycle as well. So people that are taking several hour naps often find it difficult then to fall asleep at night or to stay asleep. Problems with mood, like anxiety and depression, like I mentioned before, keeping an inconsistent schedule. Some of the other sleep disorders we talked about, like restless legs, sleep apnea, side effect of medications, all can contribute to insomnia. And we know that just having Parkinson's itself, and especially as this disease progresses, can worsen sleep and cause more insomnia. Some particular Parkinson's symptoms that make it difficult to sleep, either fall asleep or stay asleep, often include wearing off of the medications, typically really problematic in the middle of the night. The discomfort you may experience then from not moving as much, and there's some natural kind of tossing and turning that occurs in sleep, but that's probably diminished in people with Parkinson's, and you may be lying very still, get sore, or be uncomfortable, and then wake up because of that discomfort. So what do we do in terms of treating insomnia? Well, one of the first things we'll typically talk about is what we call sleep hygiene, which means keeping an excellent sleep schedule and developing healthy sleep habits. That includes regular exercise, which we know helps promote sleep and helps promote deep and consistent sleep. Avoiding things like caffeine and alcohol at the latest after 4 p.m., but ideally probably more like noon. Avoiding meals right before bedtime, which cause a rush of blood flow to the guts and dysregulate the kind of natural hormone secretion that can promote sleepiness. Minimize napping during the day, probably no more than 20, 30 minutes for a nap would be ideal. establishing a consistent bedtime routine where you're turning off the TV and avoiding screens at least an hour, hopefully 2 before lying down and turning out the lights, making sure things are calm and quiet, the lights are getting darker, there's a nice, calm, peaceful routine in the few hours before bedtime. A lot of people will recommend that if you're not able to fall asleep within about 15 or 30 minutes, you get out of bed, try walking around, maybe reading a little bit, doing something else besides sleeping, because ideally the bed is just for sleeping. And making sure your bedroom is comfortable, and that includes things like the right amount of light for your preferences, especially in a dry, arid environment like Colorado, using something like a humidifier. If you find that more comfortable, making sure bed sheets, pillows, etc., are optimized to your level of comfort. And if that's not working, we think about medical treatments. One of the first ones we may recommend for people with Parkinson's is melatonin, like I mentioned, that natural sleep promoting hormone. Medications that can increase dopamine within the brain can be very helpful, and those include especially the long-acting ones that may help you get through the night and avoid those very troublesome off symptoms or rigidity, stiffness, that sort of thing. In particular, the Nupro or rotigotine patch, which is put on every 24 hours and delivers a consistent amount of medication during that time. Longer acting forms of carbidopa, levodopa, including Rytary. And in some people, deep brain stimulation may improve sleep time and quality. When we look at studies of at least people who, do surveys, talk about surveys of your sleep before deep brain stimulation and surveys of how good your sleep is after, there does seem to be some improvement. We're still working on getting more robust data on does deep brain stimulation improve more objective things, like if we did a formal sleep study, is the sleep quality and duration better with deep brain stimulation? And the jury's still out on that, but I think there are definitely promising signs that deep brain stimulation is likely to improve sleep. Let's talk about a little bit about excessive daytime sleepiness. When we say this, we mean the tendency to fall asleep more than is desirable during the daytime. And like I mentioned before, that can be anywhere from when you're sitting on the couch reading a book or watching TV to at the dinner table or in public social events, hopefully not when you're driving, but that tendency or desire to fall asleep during the daytime when you don't want to be. And if that's an issue, we'll look especially at the quantity, quality, and timing of sleep. We'll think about all of those sleep disorders that I just talked about. And if we don't find any of those things, but daytime sleepiness is still a problem, we'll think about particular side effects of medications. And unfortunately, we often experience kind of a push and pull where those dopamine agonists, including pramipexole or Mirapex, rotigotine, can actually cause, like I said, those sleep attacks where people are falling asleep kind of suddenly and without much warning. Mental health, their mood issues, depression, anxiety definitely typically have this daytime sleepiness as a very common symptom. And if we're not getting anywhere with those, we often would recommend that you see a sleep specialist. These are people with special training in sleep disorders who can look at even more, a wider variety of issues with sleep and talk about other treatments or modalities to improve daytime sleepiness. Some medical treatments can include caffeine, and so recommending things like a cup or two of coffee in the morning, typically to improve sleepiness, are very helpful. Again, cautioning that you don't want to be using those things late in the day or evening, as they'll often keep you awake and prevent sleeping at night. Some people will use a medication called modafinil, or Provigil is the brand name. That's a stimulant that works similarly to caffeine and typically does not cause the kind of side effects that you may get with caffeine, including that jitteriness or on edge feeling, especially if you've had too many cups of coffee. So to summarize, we do think that sleep and fatigue are somewhat different. We'll often try and make a distinction between the two, but it's very common that people experience both, or we're not able to totally tease apart one from the other. Most sleep problems are treatable, and it is worth talking about your doctor with them. We talked about several common sleep issues in Parkinson's disease. Those include REM sleep behavior disorder, or that acting out of dreams, restless leg syndrome, and periodic limb movements, which often come together, insomnia, trouble falling asleep or trouble staying asleep, daytime sleepiness, and problems with breathing during sleep, which includes sleep apnea. And if we've worked through all of those and we're still not satisfied with sleep, then it's often a good idea to talk about seeing a sleep specialist. So with that, I'll wrap up and happy to take any questions. I know I did get a couple from Elena before that I hopefully addressed during the talk. I think there was one about REM sleep behavior disorder and CPAP, or using airway pressure to treat that. We think that that would not be a good or a treatment that's likely to help. CPAP, or positive airway pressure, will help the symptoms of sleep apnea because it's a physical way of keeping the airway open. But the problem with REM behavior disorder, or REM sleep behavior disorder, is in the brain and brainstem itself, as best as we know. And leads to, like I said, that loss of the normal paralysis that comes with deep REM sleep. So there's probably not a direct treatment for that with with CPAP or positive airway pressure, but you could maybe hypothesize that if sleep apnea is being treated, people may be more likely to enter the deeper stages of sleep and hopefully stay asleep longer, and maybe hopefully be able to treat their REM sleep behavior disorder.
Awesome. Thank you so much for that presentation. We do have a couple of questions that came in, and one of the pre-submitted questions that we had was also about panic attacks when this person initially lies down at night.
That's a difficult one. That is not something we typically think about as a sleep issue. It'd be helpful to know a little bit, I think, or to hear a little bit about what sort of symptoms of panic attack people experience. Certainly, is it maybe one of those, like I said, hypnic jerks or sleep starts where people are starting to fall asleep? They feel this odd sensation of falling, into the void, falling down a flight of stairs, and they wake up suddenly with a start and feel panicked. That would be something that comes to my mind. Are the symptoms of Parkinson's just worse, meaning stiffness, slowness, tremor coming out because medications are wearing off, and you're feeling kind of panicked or not right in that sense? Or are they just true panic attacks that happen to come on at night? So not something that I would say is a typical or very common issue with sleep, but I could think of, like I said, at least those few things that may be problematic that would probably be worth discussing with your doctor or neurologist.
Awesome. Our next question comes from Tara, and I actually believe you answered it right after she submitted it a little bit, but she asks, does dreaming mean you are getting REM sleep?
For the most part, yes. We think that the vivid dreams where you're in a situation, you're talking to people, it seems like real life, those are the dreams of REM sleep. There probably are some dreams of deep sleep that's not REM sleep, but those are usually much more simple, maybe just kind of quick visions or images. They're not so vivid and complex, and you may not be as likely to remember those. But when they do ask people about dreams immediately after they wake up, we think that some of those very simple, not as realistic dreams are probably outside of REM sleep. But the typical dreams where things are very vivid, seem like real life, that is a good indicator of REM sleep.
Awesome. And I should mention again, there are a couple of different ways to ask questions. If you navigate to your control panel, you can either type your questions in through the questions tab, or you can raise your hand. I see one person with a raised hand, and we'll unmute you and you can ask your question directly. So with that, our next question comes from Mary, and she asks, can melatonin be taken nightly long term, and does it affect your ability to drive the next day?
The first question, I would say yes, it can be taken nightly long term. Like I said, the nice thing about it is it's a natural hormone made by your brain. We're just giving you a little bit more. So we don't think that there's any long-term risks like becoming dependent or addicted to it. Some people, especially when they start it, do feel somewhat groggy, sleepy, out of it the next day. And I would recommend that you at least think about that and make sure that that's not the case for you before you started driving the next day. But if you wake up feeling refreshed or your normal self and not feeling groggy or sleepy, there's not a reason you shouldn't be able to drive the next day.
Awesome. Okay, we'll go ahead and try this raised hand from Sue. Sue, I'm going to go ahead and unmute you, and you can unmute yourself and ask your question directly. Oop. That might have been a mistake.
Okay.
So I'll go ahead and go to our next question from Tom, and he asks, how do you manage restless legs with PD patients taking Sinemet, in particular avoiding augmentation of RLS while achieving the right Sinemet dose for PD symptom control? These seem to be in conflict.
You're exactly right, Tom, that those sometimes are in conflict. When people have restless leg symptoms and are taking carbidopa-levodopa, we have to be very cautious and judicious about the timing and the dosing of the Sinemet or carbidopa-levodopa, especially in the afternoon and evening. We're usually at least try to make an effort to make sure that people aren't experiencing the very early signs of augmentation because that's the time to catch it before things get out of hand. Making sure that in particular restless leg symptoms aren't starting earlier and earlier in the day, or that you find that the symptoms are more severe, spreading to the arms, or even begin taking more Sinemet or carbidopa-levodopa to try and treat restless leg symptoms. And that's the thing we usually avoid is if you are taking carbidopa-levodopa and the restless leg symptoms are getting worse, we would try to avoid treating that with more carbidopa-levodopa, instead trying to treat it with things like either one of those long-acting dopamine medications like the Nupro or Rotigotine patch, which lasts for 24 hours, or medications like gabapentin or pregabalin, which do not carry that risk of augmentation, and then looking at other things like iron supplementation, either with a pill or an IV dose of iron in your diet, doing things like exercising, stretching before bed, warm baths, all those other things that we can do that don't come with a risk of augmentation. But you're right, that it is a tricky balance sometimes.
Okay, our next question comes from John, and he is heartburn typical for PD?
I think heartburn is typical for so many people that it'd be hard to say with certainty that it's more common in PD. It's very common in the general population, would be my answer to that. And you could even imagine, I don't know this for a fact, and I don't know if there's studies to support it, but if people with Parkinson's are more, let's say, immobile in bed because they just don't move as much due to the Parkinson's, that they may be more likely to lie there still and allow some of that reflux to happen, which is worse typically when people are lying flat. And they may not be as likely or as readily able to move, roll over, sit up, do the things that can, in some cases, help relieve the symptoms of heartburn.
I see. Okay, our next question comes from Steven, and he says, I know it varies person to person, but what is your recommendation for an average amount of sleep for PD patient?
You're right that it varies person to person. Typically, PD patients we don't think of as needing more sleep than anyone else in the general population. But you just need good quality sleep, and that's obviously something that we're working with in some cases and can be quite difficult. So generally, people need about 7 to 8 hours of sleep to feel refreshed and restored. And we know that as people age in general, even without Parkinson's, there's a natural decrease in the amount of sleep that you're typically able to get. For some people, they feel like they don't need as much sleep as they get older. Some people feel like they need the same amount of sleep, but they just don't get it. And we know that the structure of sleep changes as well with aging, where you spend less time in REM sleep actually as you age and more time in the lighter stages of sleep. So that may also affect the amount of sleep that you get as you age, and whether that's due to the Parkinson's or due to just the fact that we're all aging is a little bit difficult to say. So my answer would be probably the normal amount, which is typically 7 to 8 hours, but making sure that it's good quality sleep can be more challenging in people with Parkinson's.
Great. Our next question comes from Robert, and he asks, after a sleepless night, how do you catch up on lost sleep without long naps?
That's a tough one. I would say that, doing things like maintaining a wakefulness promoting environment as best as you can. And so even though you may feel tired, trying not to spend the whole day, let's say on the couch or taking naps during the day, getting some exercise as best you're able, getting some natural light, making sure the environment is changing up, whether it's, because we're spending so much time at home these days, just moving from room to room, getting outside the house, getting some vitamin D could all be helpful. But that's very difficult, and I know those restless nights can be lead to very problematic and distressing days. And certainly, kind of short power naps would be helpful as well. But I wouldn't try and think of it as catching up on the balance. Let's say you only got 4 hours of sleep at night. I wouldn't try and get 4 hours during the day to make up the difference. Use the power naps as you can and as you're able. And then do those other things like I mentioned, trying to maintain a stimulating and active environment.
Awesome. Okay, so our next two questions come from Jane, and she asks, is REM sleep the same as deep sleep?
So the answer is no. The deepest stage of sleep, typically we think of sleep as several stages. There's stage 1, 2, and 3, with 1 being the lightest sleep, 3 being the deepest sleep, which is probably most important for things like memory consolidation, that sort of thing. And REM sleep is kind of this strange in between where it has features of very deep sleep, but also features of very light sleep in terms of activity in the brain. And if you look at the EEG or the electrical activity of the brain, it looks almost like a person who's awake, but other things look like a very deep sleep in terms of body temperature, that sort of thing. So REM sleep is kind of an in-between or a mix, but it usually follows the deepest stage, which is stage 3 of sleep.
Awesome. And I know in one of your previous answers, you said that patterns of sleep change as we age, but Jane also asks, what's a normal amount of deep sleep during a night?
A normal amount of deep sleep, again, that is where we usually see the biggest change as people age. And so whereas, someone in their, let's say 30s to 40s or even 20s might get, I would say probably on the order of 2 to 3 hours of deep sleep throughout the night. As people age, we see less and less in that, where it can be an hour or even less. Some people with very disordered sleep, sleep apnea, that sort of thing, might not actually get any sleep throughout the night, and that may feel normal to them. It may also feel very abnormal, and that they're very fatigued, sleepy during the day. So there's a whole lot of variability, but I think, there's some trend between a few hours when we're kind of young in 20s, 30s, 40s to as little as none as we get into our 60s, 70s, or 80s.
Wow, that's quite the change.
It is.
Okay, so I don't see any other questions coming in currently, so I'll go ahead and start wrapping up. First of all, thank you so much, Dr. Baumgartner, for presenting on this topic. I know it's such an important part of everyone's lives, and anything we can do to make our sleep better is important. Again, this is going to be recorded, or this is recorded, and will be available to you in a follow-up email sent out around this time tomorrow, or we're going to get it up on our YouTube channel later today. And again, there is a survey right after this, so just take a couple minutes to fill that out for me. That would be much appreciated. And with that, I will sign off and say thank you.
And thanks so much to you.
Yeah, have a good one.
All right, bye-bye.